Good morning, one and all. Today, we are going to discuss about the extraoral radiography. Myself, Dr. Kansha Budakoti, I am Associate Professor in the Institute of Dental Studies and Technology, Modinagar, Ghaziabad. These are the headings in which the lecture will be covered, that is Introduction, Extraoral Radiographic Technique, in which we will be covering about the panoramic radiograph, various skull views like PA skull, AP skull, PA cephalogram, Towns view, segmental vertex view, lateral skull view. To evaluate the various anatomical landmarks, we can go for the extraoral radiograph. Like for maxillary sinus, we can go for the PA Waters view, Gragnus view, various modification of it. For evaluating the mandible, we can go for the PA mandible, lateral oblique view. To evaluate any disorders which is associated in TMJ, temporomandibular joint views like transcranial view, transpharyngeal view, transorbital view, and reverse town view. If we talk about the introduction of extraoral radiograph, what is extraoral radiograph? It is something which we place outside the mouth. So, extraoral radiograph are taken when the large area of the skull or jaw must be examined or when patients are unable to open their mouth for film placement. Extraoral radiograph are very useful for evaluating the large area of the skull and jaw but are not adequate for the detection of the changes such as early stages of dental caries or the periodontal diseases. There are many types of extraoral radiographs. Some types are used to view the entire skull, whereas other types focus on the maxilla or the mandible. So, if we talk about the indication of the extraoral radiograph, when we indicating these radiograph to the patient, when it is not possible for a patient to open his mouth because of the trismus, some type of gag reflex, or patient is uncooperative, when the operator is not able to place the film intraorally because of the restricted mouth opening of the patient, or to examine any extent of the large lesion, especially when the area of pathology is greater than which can be covered in the small IOPA films, that is intraoral periapical film, or when the jaw or other facial bone have to be examined for evidence of any disease lesion and other pathological conditions. To evaluate any skeletal growth and development, for any orthognathic surgeries, to evaluate the status of the impacted teeth, to go for the disinfection, to evaluate any trauma, to evaluate any temporomandibular joint disorders, to study skull bones for its involvement to the diseases, to detect and assess involvement of a jaw by metastasis lesion, to study any disorder which is involving our maxillary sinuses, to detect and study extent and the nature of the oral and maxillofacial trauma, preoperative, intraoperative, and postoperative assessment in the orthodontics or any kind of surgery patient has underwent. There are several drawbacks of extraoral radiographs like magnification occur due to the greater object to film distance. Detailed are not well defined due to the use of the cassette and intensifying screens. For optimum balance between the loss of image detail and reduction of the patient exposure, medium or high speed screens fill combination and contrast is reduced as the secondary radiation produced by the soft tissue is the more. So before we start with any extraoral technique, we should be well aware of some of the terminologies which has been used in every technique. Like some of these are the planes which we keep in mind while taking these techniques, that is mid-sagittal plane, second is infraorbital plane, third is canthomeatal line or orbitomeatal line, and last is the FH line, that is Frankfurt horizontal line. Mid-sagittal plane is determined by keeping the line that is coincident with the sagittal suture between the upper margin of the parietal bone running from the top of the skull till the backward. Next line is the infraorbital line. This line runs across the face from one infraorbital margin to the other. In the true lateral position, the infraorbital line is at the right angle to the film. So the third line is the orbitometer line, or also known as the canthometer line. This is an imaginary line which has been drawn from the outer canthus of the eye to the tragus of the ear. This is also known as the radiological baseline and joins the upper edge of the auditory meatus with the outer canthus of line, which has been shown in the figure. And last is the Frankfurt horizontal line. is this the line which runs from the most inferior portion of the infraorbital margin of the orbit to the highest point on the superior surface of external auditory meatus. Based on the area of the interest, if we want to see any defect, any pathology associated in the skull view, we can indicate various skull views like PA skull, submental vertex view, which is the base of the skull, lateral skull, lateral cephalogram. If we want to evaluate any disorder, any pathology associated with these maxillary sinus, we can go for the Waters view, which is also known as paranasal sinus view, modification of Grandner's view, cadval projection. If you want to see anything related to the mandible, then lateral oblique views, that is body and the ramus. And last is the TMJ view, which we can go for the transcranial, transpharyngeal, transorbital and the reverse down view. Now, various technique for radiography of the paranasal sinuses, we can go for the PA projection and the inclined PA projection. For any maxillary sinus radiography, we can go for the standard occipital projection, that is 0 degree, then the 30-degree modified method of the 0 degree, PA Waters, and last Bregma Ventil. Evaluating any pathology associated with the mandible, we can go for 3 radiographs, that is PA mandible, rotated PA mandible and the lateral oblique. For the base of the skull, submental vertex projection. For evaluating the zygomatic arches, jug handle. For TMJ projection, transcranial projection, transpharyngeal projection, transorbital projection, reverse down projection. For evaluation of any pathology, any disorders, any trauma associated with the skull, we can go for the lateral cephalogram, true lateral, PA cephalogram, PA skull and Townes projection. And last is the orthopentomogram. So first is the radiograph of the paranasal sinus. PA projection, which is also known as posterior anterior projection. There are two methods for obtaining this projection. First is the posterior anterior, which is also known as Grander's projection, and next is a modified method, which is inclined posterior anterior and known as cadval projection. First is posterior anterior projection, which is also known as Granule projection. And what all these structures which we can see in this projection is inner and middle ear, frontal sinuses, anterior ethmoidal sinuses, sphenoidal sinuses, and some part of maxillary sinus which is superimposed. If we talk about the film placement, the cassette is placed perpendicular to the floor in the cassette holding device, and the long axis of that cassette is positioned vertically. Patient position is like the mid-sagittal plane should be vertical and perpendicular to the plane of cassettes. Only the forehead and the nose of the patient should touch the cassette, and the radiographic baseline is at 90 degrees to the film. Then the central ray should pass or directed to the midline of the skull so that the X-ray beam passes through the cantometal plane perpendicular to the film plane. Now in this slide you can see that the diagram is showing that the film is placed perpendicular to the floor and the patient position mid-sagittal plane should be vertical and the perpendicular to the plane of the cassette. The CM line, cantometal line should be at 10 degree to the film. Patient forehead and nose should touch the cassette, and the central ray which is directed perpendicularly from the backward of the skull. This is a PA view which we can see it's showing the nasal septum, frontal sinus, maxillary sinus, ethmoidal sinus, inferior turbinates, superior orbital fissure, sagittal suture, coronal suture, sphenoidal ridge, mastoid process, hard palate, eminent lines and petrous ridge. Second is the modified method or inclined posterior anterior and also known as cadval projection. It is also known as occipitofrontal view or the nose forward. And what all structures shown in this cadval projection, because of this angulation which causes the petrous ridge to be superimposed on the maxillary sinus and thus allowing more accurate examination of the orbit and the ethmoidal ear cells. Film placement for this projection should be like this. The cassette is placed perpendicular to the floor in the cassette holding device and the long axis of this cassette should be positioned vertically. If we talk If we talk about the position of the patient, the mid-sagittal plane of the patient should be vertical and perpendicular to the cassette. Only the forehead and the nose touch the cassette so that the canthomedial line is perpendicular to the cassette. On the resultant radiograph, the superior border of petrous ridge is projected in the lower third of the orbit, and the central ray is directed 23° to the canthomedial line, entering the skull about 3 cm above the external occipital protuberance and exiting at the glabellar point. In this diagram, you can well appreciate the positioning of the cassette, positioning of the patient, and the entering of the X-ray source. In this diagram of the positioning, inclined posterior anterior projection, which is showing that the central ray, which is passing at the 23° to the canthomedial line, entering the skull about 3 cm above the external occipital protuberance and exiting the glabella. These are the structure which has been shown in this modified Calvert projection. Various sutures like sagittal sutures, lambdoid sutures, sinuses like frontal sinuses, ethmoidal sinuses, various cells, mastoid cells, petrous ridge, maxillary sinus, nasal septum, and the base of the skull. Next is the radiographic of the maxillary sinuses, in which we will be covering the 0°, 30° PA waters and bregma mental. First is the standard occipitomental projection, that is 0° OM, and the structure shown are the projection shows the facial skeletal, maxillary entra. It avoids superimposition of the dense bone of the base of the skull and is especially useful to detect middle third fractures, that is leaf 1, 2, 3 fractures, zygomatic complex, nasoethmoidal complex, orbital flow, blowout fractures, and the coronoid fractures. Film placement of 0° OM, the cassette is placed perpendicular to the floor in the cassette holding device and the long axis of the cassette should be positioned vertically. If we talk about the position of the patient, the mid-sagittal should be vertical and perpendicular to the plane of the cassette. Only the nose and the chin should touch the cassette. The head is stepped back so that the radiographic baseline is at the 45° to the film, and central ray is directed horizontally through the occiput. If we talk about the exposure parameters, these are the fixed parameters in the machine, and in this slide you can see the standard occipital view which has been positioned as radiographic baseline in the 45° to the film. X-ray beam is directed perpendicular to the film. This figure shows the various color line which are useful in determination of anatomical references to assess any facial bone injuries. These are Campbell's line, which has been denoted by the colors like red, orange, green. If we talk about the red, which is the upper line which passes through the zygomatico-frontal suture and across the upper edge of the orbit. If we talk about the middle line, which is orange color line, which follows the zygomatic arch, crosses the zygomatic bone and follows the inferior orbital margin to the opposite side. And the last lower line, that is green, which passes through the condyle and the coronoid process of the mandible and through the lateral and medial wall of the maxillary entra on the each side. Midline, which is used to assess any asymmetry. Next is the modified method, that is 30° occipitomental projection, and the structure shown are the facial structure skeleton from a different angle, enabling certain bony displacement to be detected, useful in detecting middle third fractures, leaf 1, 2, 3, and the coronoid process fracture. Film placement is placed perpendicular to the floor in the cassette holding device and long axis of the cassette is positioned. Position of the patient, the mid-sagittal plane is vertical and perpendicular to the cassette. The head is centered so that the nasion is in the center of the cassette and only the nose and the chin should touch the cassette. The head is stepped back so that the radiographic baseline is at 45° to the film. Central ray is directed at 30° to the horizontal, centered through the lower border of the orbit, and these are the exposure parameter used in this projection. In this slide, you can see the radiograph which is showing the 30° occipitomental view, and on the left side the diagram which is showing the position of this 30° modified OM projection, in which the radiographic baseline is set at the 45° to the film and the X-ray beam is aimed downwards at the 30°. These are the indication which we can see in this projection, that is Leaford 1, 2, 3 fracture and the coronoid fracture. Next is the Bregma-Menton view, in which the structure shown are the primarily used to demonstrate the wall of the maxillary sinuses, the orbit, zygomatic arches, and the nasal septum. It also demonstrates medial and lateral deviation of any part of the mandible. Film placement. Cassette is placed parallel to the floor in the cassette holding device or the table, as you can see on the right corner of the slide. Position of the patient. The mid-sagittal plane should be vertical and perpendicular to the plane of the film. In this diagram, there is a positioning of Bregma-Menton projection. The chin is extended as far as possible, and let's see the Bregma-Menton view. Next is a PA Waters view. In this, the structure shown are the maxillary sinus, frontal and ethmoidal sinuses. Sphenoidal sinuses can be seen if the patient is asked to open his mouth, whereby the sphenoidal sinuses are projected on the palate. If we ask the patient to open his mouth, then the sphenoidal sinuses can be seen clearly. Otherwise, these are projected on the palate. Other than these, orbit, fronto-zygomatic suture, nasal cavity, coronoid process of the mandible, and the zygomatic arch can be visible in this PA Waters. In this diagram, there is a positioning of PA Waters projection. The radiographic line is set at the 37° to the film, and the X-ray film, which is passed perpendicular to the film. This is the X-ray of Waters view, in which you can well appreciate the frontal sinuses, bony nasal septum, anterior nasal spine, coronoid process, condyle, mastoid process, mandible angle, preterus ridge, mandible, zygomatic arch, zygomatic bone. Next are the radiograph of the mandible, and it has been divided into PA mandible, rotated PA mandible, lateral oblique. If we talk about the PA mandible, the structures shown are the body and the ramus of the mandible. An indication, fracture of any 1/3 of the body of the mandible, any fracture of angle, ramus, or the lower condyle neck. If we talk about the mediolateral expansion of the posterior 1/3 of the body and ramus in the cases of tumor and cystic lesion, these PA mandible is very useful to detecting any mandibular hypoplasia or the hyperplasia. In this diagram, you can see the position of PA mandible projection. The radiographic baseline and the X-ray beam are perpendicular to the film. The evaluation, the structures which has been shown in this radiograph is the condyle, coronoid process, ramus, body, and symphysis area. Next is the rotated PA mandible. Structure shown in rotated PA mandible is used to show the tissue of the one side of the face and used to investigate the parotid gland and the ramus of the mandible. Indication, any stone, calculi in the parotid gland, as we told about the structure shown, and one of the structure which has been well appreciated in this radiograph is the parotid gland. So indication for any calculi or stone present in the salivary gland. Lesions such as cyst or tumor in the ramus of to note any mediolateral expansion, or the submesenteric infection to note any newborn formation. These are the structure which is shown in this radiograph: mastoid air cells, petrous temporal, condyle neck, border of the inferior orbital fissure, floor of the orbital, zygomatic arch, maxillary antrum, and angle of the mandible. Then comes the lateral oblique, and in lateral oblique, first is the interior border of mandible, in which the structure shown are the anterior border of the mandible, position of the teeth in the same area. Indication, evaluation any impacted teeth, any fracture, lesion associated in the anterior portion of the mandible. This is the radiograph, which is the lateral oblique for the body of the anterior mandible. Next is the posterior body of the mandible. Structure we can appreciate in this is the body of the mandible, position of the teeth, same area, ramus of the mandible, angle of the mandible. An indication used to evaluate any impacted teeth, any fracture, lesion located in the posterior border of the mandible. This is the X-ray, which is showing you the posterior body of the mandible, condyle, ramus, mandibular angle, body of the mandible, mentum, and the coronoid process. Next is the ramus of the mandible. Structure shown in the ramus of the mandible is a view of the ramus from the angle of the mandible to the condyle, an indication for evaluation of any impacted molar, large ridge, or any fracture which is extending into the ramus of the mandible. This is the anatomical landmark which we can see in the ramus area. Next is the radiography of the base of the skull. Segmental vertex projection or SMV view structure seen is the base of the skull, sphenoidal sinuses, and any facial skeletal from the below of the skull. Indications of the SMV view is to evaluate any destructive expansile lesion affecting the palate, pterygoid region, or the base of the skull. Investigation of the sphenoidal sinuses, assessment of the thickness of the posterior part of the mandible before stomy, any fracture of the zygomatic arches to show these thin bones. The SMV view is taken with the reduced exposure factors. Film placement, the cassette is placed perpendicular to the floor. Position of the patient head and neck tip back as far as possible. The vertex, that is top of the skull, should touch the cassette, and both the sagittal planes should be perpendicular to the plane of the film. If we talk about the central ray, it is directed perpendicular to the film. It enters through the mid-sagittal plane between the angle of the mandible and the coronal plane, 3/4 inch anterior to the external perimeters, and in order to view the vitreous portion, the central ray is directed at the right angle to the film midway between the external auditory meatus. This is the radiograph which showing the major anatomical features like zygomatic arch, frontal sinuses, upper lower incisors which is superimposed, lateral wall of the orbit, anterior margin of the cranial fossa, pterygoid plates, condylar head, anterior arch of the atlas, foramen magnum, mastoid air cells, occipital condyle, auditory canal, foramen spinosum, foramen ovale, sphenoidal sinuses. Then next comes jug handle view, which is the modification of the previous view, that is of the submental vertex view. Structure seen in this jug handle view is the symmetrical axial view of the zygomatic arch. And how we achieve this symmetrical axial view of this zygomatic arch? By reducing the exposure time 1/3 of the normal exposure time for the SMV projection. Next comes radiograph of the temporomandibular joint. First is a transcranial view, in which the structure seen are the lateral aspect of the glenoid fossa, articular eminence, joint space, and the condylar head. The indication for the transcranial view is the TMJ pain dysfunction syndrome, any internal dearrangement of joint which may be producing any pain, clicking, or limitation in the mouth opening. To investigate the size and the position of the disc, this can only be inferred directly from the relative position of the bony element of the joint and to investigate the range of the movement in the joint. Now in the slide you can see 4 different pictures showing the transcranial projection. Figure A and C is the transcranial position in the mouth closed, and in the 12.14b and D is showing the transcranial projection in the mouth open condition. In this transcranial projection, the central ray is oriented at the 25-degree positive angle from the opposite side and anteriorly 20 degrees centered over the TMJ of interest. Both are same, both angulation, both center of rays will be same while taking mouth open or closed. But the X-ray which will come after closed mouth, in which you can evaluate that the condyle is in the fossa, whereas when the mouth is open, it has been addressed anteriorly. The diagnostic information of open mouth and closed mouth is like that. The open mouth, the range and the type of the movement of the condyle you can see, the comparison of the degree of the movement of the both side you can evaluate, whereas in the closed mouth, the size of the joint space you can evaluate, the position of the head of the condyle within the fossa, the shape and condition of the glenoid fossa, and the articular eminence, the shape of the head of the condyle, condition of the articular surfaces, and the comparison between the both of the side of the condyle and the fossa you can do in this transcranial projection. In this, we have shown the example of the normal transcranial radiograph of the right TMJ and the same radiograph with the major anatomical feature which has been projected through this radiograph. Next is a transpharyngeal, which is also known as infracranial or McCune-Dell technique. Structure shown in this McCune-Dell technique is the lateral view of the condylar head and the neck of the articular surfaces. Indication: TMJ pain and dysfunction syndrome to investigate the presence of joint disease, particularly the osteoarthritis and the rheumatoid arthritis to investigate any pathology condition affecting the condylar head, including cyst or tumor, or any fracture associating the neck and the head of the. In this, the positioning of the left pharyngeal view is shown, in which the film is placed like cassette is placed against the patient ear, and the center point is ½ inch anterior to the external auditory meatus over the TMJ of the interest parallel to the sagittal plane. If we talk about the patient position, sagittal plane of the patient is vertical and parallel to the film, and patient should open his or her mouth. While the central ray vertical direction, it is directed at the -5 degree to the 10 degree from the sigmoid notch or the contralateral side. Horizontal direction angulation if we talk, then the 10 degree posterior to the TMJ interest. It's what all structure we can see is the medial surface of the condylar head and neck in the mouth open position. This is an example of transpharyngeal radiograph of the normal left condyle, in which you can appreciate the condylar head. There is a standard process, shed of the soft of the palate, hard palate, coronoid process, pterygoid plate, zygoma, and the pterygopalatine fossa. Next is the transorbital, which is also known as Zimmer projection view structure, which we can well appreciate in this transorbital projection is the anterior view of the TMJ joint. Medial displacement of the fractured condyle, fracture of the neck of the condyle are clearly seen in this view. Transorbital projection, the central ray is oriented downward approximately 20 degree and laterally approximately 30 degree through the contralateral orbit center over the TMJ of interest. And transorbital position, the cassette is placed behind the condyle and X-ray is projected across the orbit. Next is the reverse down view projection, in which the structure seen is the posterior view of the both condyle heads and neck, indication that to investigate any articular surface of the condyle and disease associated within the jaw, fracture of the condylar head and the neck, and any condylar hypo or hyperplasia. Structure which is shown in the reverse down are mentioned in this radiograph. Coming to the next projection, that is skull projection, that is lateral cephalogram, true lateral, PA cephalogram, and Townes projection. First is a lateral cephalogram. Indication for lateral cephalogram is the evaluation or formatting any initial diagnosis, confirmation of underlying skeletal, any soft tissue abnormalities. It helps in making the treatment plan, monitoring treatment progress, example to assess any anchorage requirement, any incisal inclination requirement. Appraisal of the treatment results, example 2 months before the completion of the active phase treatment to ensure the treatment targets have been met to allow the planning of the retention, to evaluate any orthokinetic surgeries, pre-operative evaluation, post-operative evaluation of any skeletal and soft tissue pattern to assess in the treatment plan, post-operative appraisal of the surgery, result of the surgeries. This is the lateral cephalogram, which is showing the frontal sinus, nasal bone, maxillary sinus, maxilla, mandible, ramus, condyle, sella turcica, greater sphenoidal wing, and orbital roof. True lateral, if we talk about the true lateral structure seen in the true laterals, it's a skull vault and facial and skeletal from the lateral aspect. Indication fracture of the cranium and the cranial bone, midline third fracture to show possible downward and backward displacement of the maxilla, and investigation of the frontal, sphenoidal, and the maxillary sinuses. Condition affecting the skull vault, particularly in the case of Paget disease, multiple myeloma, hyperparathyroidism, condition affecting the sella turcica, such as tumor of the pituitary gland in the acromegaly cases. This is the same radiograph with the major anatomical features which has been shown in this slide. PA cephalogram structure seen is this projection is the identical to the PA view of the jaw, except that it is a standardized and the reproducible. This makes it suitable for the assessment of the facial asymmetry and for the pre-operative and post-operative comparison in the orthokinetic surgery involving the mandible. Indication for this projection is used for the assessment of the facial asymmetry, pre-operative and post-operative comparison in the orthokinetic surgeries involving the mandible. This is a PA cephalometric view with the anatomical landmarks which has been shown in this radiograph. Indication used for the assessment of facial asymmetry, preoperative and postoperative as explained before in the previous slide. Next is the down projection. Indication Articular surface of the condyle can be evaluated, diseases within the joint can be seen, fracture of the condyle, head and neck and intercapsular fracture can be determined, and in the case of hypo and hyperplasia of the condyle. Area of joint seen are the posterior view of both condyle head and the neck. If we talk about the film position, cassette placed perpendicular to the floor, position of the patient, sagittal plane vertical and perpendicular to the film. Only the forehead should touch the film. Mouth should be wide open and angle of the X-ray should be at 30° to the film. This is the radiograph which has been shown after the projection. Next is the panoramic radiography. Introduction. If we talk about the panoramic, which is also known as OPG, panoramic imaging, also called as pantomography, is the technique for producing a single tomographic image of the facial structure that includes both the maxillary and the mandibular dental arches and their supporting structures. This is a curvilinear variant of the conventional tomography. Principle of panoramic image formation. It was given by the Petro and the Numata sir, which described the principle of panoramic radiography is based on the principle of reciprocal movement of the X-ray source and the image receptor around a central point or plane, which is known as image layer, in which the object of image is located. Objects in front or behind this image layer are not clearly captured because of their movement relative to the center of rotation of the receptor and the X-ray source. If we talk about the principle, panoramic image is a technique for producing a single topographic image of the facial structure that include both the maxillary and the mandibular arches and their supporting structures. It is a linear variant of the conventional tomography and is based on the principle of the reciprocal movement of an X-ray source and the image receptor around a center point or a plane called as the image layer, in which the object of the interest is located. Now in this slide you can see the diagram of the film X-ray source tube head, which is showing from start to the end. In this, the figure depicts the rotation motion of the X-ray tube behind the patient head and the simultaneous movement of the film cassette in the front of the head. So you can understand, if patient is placed in the center, then on the patient front there will be a cassette and patient back there will be a X-ray tube. So two different things are placed in front and in back of the patient head. The film itself moves in the opposite direction behind the lead shield within the cassette during the rotation, and in this example the image of the shaded area of the jaw is being named. If we talk about the rotation center point, this is the pivotal point or axis around which the cassette carrier and the tube head rotate and is termed as rotation center. There are three basic rotation center used in the panoramic radiograph. First is double center rotation, second is triple center rotation, and there is a moving center rotation. The location and the number of rotation center influences size and the shape of the focal structure. In this figure, the sliding path of the center of rotation is depicted. The center of rotation moves as the X-ray rotates around the back of the head. When the center of rotation is on the right side, the image of the left side is being made. That is, when the CR is on the right side, then the image will be made of the opposite side. Next is the image layer. What is image layer? It is also known as the focal trough. It is a three-dimensional curved zone where the structure lining within this layer are reasonably well defined on the final panoramic image. The structures seen on the panoramic images are primarily those located within this image layer. An object which outside this image layer are blurred, magnified, and are reduced in the size. Even the distortion can be appreciated. Thus, this size of image layer varies with the brand of the equipment used. This is a focal trough. You can see that the ABC is the X-ray source, then X-ray beam is there, and there is a film, and in between there is a patient. This blue dot is the center of rotation. It is a third dimensional curved zone in which the structures are clearly demonstrated on the panoramic radiograph. Object in the front or or the behind the image layer are blurred because of their movement related to the center of the film and the X-ray source. The image layer thickness depends upon the effective projection radiation and radius and the width of the beam. The closer the rotation center to the teeth, narrower the focal trough. In the most machine, the focal trough is narrow in the anterior region and wide in the posterior region. Then the factor affecting this image layer of focal trough is the arch path, velocity of the receptor X-ray tube head, alignment of the X-ray beam, collimator width, location of the image layers, and as the position of the object is moved within the layer, image layer size and the shape of the image layer change. Then what is the center of rotation? The film and tube head are connected and rotate simultaneously around a patient during the exposure. The axis around which the film and X-ray tube rotate is termed as CR, that is center of rotation. And depending upon the manufacturer, the number and the location of the center rotation differs, like single center rotation, double center rotation, triple center rotation, and the sliding center rotation. Now coming to the single center rotation, Dr. Betu applied the principle of curved surface tomography to the circular tomography, example the radiograph machine. This technique used the stationary rotation center of the beam placed at one side of the jaw, and the rotation center is then shifted symmetrically by moving the patient, and this projection technique produced the split image. Next is two center of rotation. The individual left and right side of the arc formed by the teeth and jaw closely form a part of circle. The center of rotation was positioned anteriorly to the location of the third molar opposite the side being examined, and this double rotation principle was used in the Panorex machine. In this figure, you can well appreciate the double center of rotation. Then the three center of rotation. This system divided the arc of jaw into three areas, that is a condyle to the first premolar posterior segment, second is a canine to the canine anterior segment, and third is the contralateral opposite segment. These three curved segments have been different centers. Two are bilateral situated slightly posterior lateral to the third molar, and the third one is situated midline to the posterior X-ray. The X-ray beam can be shifted from one center to other without any interruption, and the continuous image can be made from the condyle to condyle. And example of three center of rotation is the panorama, and the orthopantomogram. This is the figure of the three center of rotation. You can see the location of the red dot where it has been situated. Next is the sliding moving center of the rotation. The center of rotation changes as the film and the tube head rotates around the patient. The rotational changes allow the image layer to conform to the elliptical shape of the dental arches. All the machine employs a moving rotational center that traces a path of shape of an ellipse. So the system is also called as ellipsopantomography. This is a sliding center of the rotation. This is an anterior center rotation. This is a part of sliding center rotation and the lateral rotation center. This is a focal trough which we have already discussed in the previous slide. These are the panoramic machine with the digital receptor, X-ray source, OPG machine which is being readily available in the market. Then the exposure parameters, voltage, tube current, time, dosage of the patient, kVp, voltage 75, tube current MA, milliampere 15, time in second and 15 seconds, and dose of the patient. Then in the case of full mouth examination with 14 intraoral film exposure, the what should be the dosage? Should be the voltage 60, tube current MA should be between the 7 to 10, and time should be between the 1 to 1.5 second per film. This is the picture showing the patient positioning. So we have to prepare the patient, remove all the removal appliances, metallic hair clips, necklaces, chain, earring, tongue, lip rings should be also removed if at all possible. Explain the procedure to the patient, make the patient wear a lead apron without a thyroid collar, prepare the machine, disinfect the machine, place a new bite stick in the machine. Then we have to follow several planes like Frankfurt plane and mid-sagittal plane. Then patient should be straight as possible. The patient neck should be extended. Interior teeth should be in the notch on the bite stick. The mid-sagittal plane should be perpendicular to the floor and aligned with the vertical center of the chin rest. FH plane should be parallel to the floor, and tragus of the ear must be aligned with the plastic guide. Center the lower border of the mandible on the chin rest and is from the each side. Indication: as a substitute for the all full mouth intraoral periapical radiograph, you can indicate for those cases evaluation of any trauma, evaluation of tooth development in the mixed dentition for the children, orthodontic treatment evaluation, developmental anomalies of the tooth, third molar, disinfection for the disinfection cases, large lesion like cyst tumors, detection of the any fractures, generalized disease, inability to tolerate intraoral films, assessment of the surgical procedures. This is a full mouth view of orthopentomogram. This is the evaluation of the third molar. You can well appreciate the 1-8, 3-8 and 4-8. 1-8 mesoangular disinfection, horizontal disinfection and the mesoangular disinfection. It can be used for the orthodontic treatment, as you can see the braces. Next, it can be used for any evaluation for the any developmental anomalies. Next, for any mixed dentition in children, any malignancy involving bone, maxilla, mandible. It, it has several contraindications like panoramic film are not as defined as sharp as the images seen on the intraoral film, can't use where required, fine anatomical detail cannot be achieved by the OPG, small carious lesion cannot be appreciated in the OPGs, fine structure of marginal periodontium cannot be evident, periapical diseases cannot be well appreciated, and for equal magnifications. Advantage: if we talk about several advantage, then it is well tolerated by the patient, minimal time to expose when compared to intraoral radiographs, broad anatomical coverage can be achieved by the help of OPGs, relatively low patient dose for object localization in conjunction with the occlusal radiography. If we talk about the disadvantage of OPG, then resolution is not good as the intraoral radiograph film. This results in the loss of detail, superimposition of the real double images on a only object in the focal trough can be seen clearly, distortion of the images, overlapping of the teeth, magnification of the teeth, object of the interest outside the focal trough are distorted and the blurred. This is a small figure presentation of the actual size of the tooth surface, and when it can be magnified in the OPG, then it is magnified by 20 to 30% horizontal and the vertical angulation. Now we will talk about several anatomical landmarks which we can well appreciate in OPGs. Now we will talk about the landmarks in the mandible. First is the condylar head, second is your sigmoid notch, third is your coronate process, fourth is your external oblique ridge, fifth is your mental ridge, sixth is your posterior border of ramus, seventh is your corneal angle, eighth is your lower border of mandible, ninth is your mental ridge, 10th is your genial tubercle, 11th is your mental foramen, 12th is your external oblique ridge, 13 is your lingula, and 14 is your hyoid bone. Now coming to the bony landmarks in the maxilla. If we talk about the landmark, first is the 15, which is your glenoid fossa. 16 is the articular eminence. 17 is the zygomatic arch. 18 is the posterior wall of maxillary sinus. 19 is your maxillary sinus. 20 is the zygomatic process of maxilla. 21 is your hard palate. 22 is your flora forbid. 23 is the nasal septum. 24 is the incisor foramen. 25 is your inferior concha, 26 is your meatus, 27 is the frontal process of zygomatic bone, 28 is the pterygomaxillar fissure, 29 is the spine of the sphenoidal bone, 30 is the maxillary tuberosity, 31 is the lateral pterygoid plate. Coming to the other structure, if we talk about the other structure, first we can see the external cortex meatus. 33 will be the standard process. Then shadow of the earlobe, then your nose, then your shadow of the cervical spine, then cervical vertebrae, then nasopharyngeal space, shadow of the uvula, and last submandibular fossa. This is the OPG, which is showing of the intermaxillary fixation in the lower left mandibular region, which along with the disaffection in upper OPG, that is the mesoangular in 3-8 and 4-8 region. Next is the OPG, uppermost OPG showing the mixed dentition, and the lower OPG showing the pathological lesion. Next is the OPG showing the fracture of the angle of the right side, and lower is the edentulous region. Bony landmarks of mandible and surrounding structures. These are mandibular condyle, coronoid notch, coronoid process, ramus, mandibular foramen, lingula, mandibular canal, mental foramen, mental ridge, mental fossa, lingual foramen, genotubercle, inferior to border of mandible, mylohyoid ridge, internal oblique ridge, external oblique ridge, angle of the mandible, and dentition. Then various air spaces which we can appreciate, that is palatoglossal air space, nasopharyngeal air spaces, and the glossopharyngeal air spaces. If we talk about soft tissue images, that is tongue, earlobe, nasal cartilage, soft palate, nasolabial fold, soft palate, and uvula, and the lip line. There are many ghost and artifactual shadows like of cervical vertebrae, body, condyle, ramus of contralateral side of the mandible, palate, chin rest, right or left marker of the machine, neck chain, napkin chain, your earring, tongue ring, shoulder straps of the protective aprons. Artifact, if we talk about the artifact, various artifacts seen in the OPGs are ghost image, leg apron artifact, patient positioning error, and cassette positioning error. If we talk about the real image, so how this real image is formed? It is formed when the object is in between the center of rotation and the image receptor. Now, center of rotation is where the dot, which you can appreciate in the mandible side, and the receptor is your this image receptor or film, which has been demarcated as an AP, and your object is a oval shaped ring which is being depicted as an AP. Next is ghost image. So what is ghost image? It is an radiopaque artifact seen on the OPG film. Ghost image is formed when the object is in between the source and the center of rotation, and it is produced when the radio-dense object is penetrated twice by the X-ray beam. It resembles its real counterpart and has same morphology. It is always larger than its real counterpart. The horizontal component is severely magnified, whereas the horizontal component is not severely magnified. Then this is the ghost image, as you can see, which I have already told in the previous slide, that ghost image, it is image when the object is between the source and the center of rotation. Okay, so this dot is your center of rotation and your source is X-ray tube, and this is the image receptor AP, and AP with oval shape is between the CR and source is your object. Then structure which are often ghosted are anatomical structures like hyoid bone, cervical spine, inferior border of mandible, and non-anatomical structures like earrings, tongue ring, neck chain, chin rest, shoulder straps of vertebrae, and the marker of the. Now in this image, in this OPG, you can well appreciate the radio-opaque structure which is lying in, in the center of the central incisor of maxilla and mandible, and a shadow, a radio-opaque oval shadow in the periapical region of 2-1 and 2-2. That is the non-anatomical ghost images of the earring, chain, which are superimposed in these region. Next is the ghost image of the earring, which you can well appreciate in the right and left ears. Then there is one double image. It is a real image, which may be a double image. Double image are formed in the zone in central region. Common double image includes hard palate, soft palate, and hyoid bone. Double image of the vertebral column. You As you can appreciate in this OPG, there is right and left, which has been marked with the blue arrow. This is the double image of the vertebral column. Then common error which we should avoid during taking the OPG is the shadow of the vertebral column. You can well appreciate the radiopaque shadow in the center of the LI and central incisors, usually from patient not standing straight. When the patient is not standing straight, then this shadow comes in the center of your OPG. Next is this OPG, which is depicting your shadow of the vertebral column. Then shadow of the lead apron. This is the shadow of the lead apron. Then there are some patient positioning error also. First is the positioning of the lip and teeth. If the lip are not closed on the bite block, a dark radiolucent shadow obscure the anterior teeth. If the tongue is not contact with the palate, a dark radiolucent shadow obscures the apices of the maxillary teeth. So if lip is not closed, then there is a radiolucent shadow on the anterior teeth, and if tongue is not in contact with the palate, then the dark radiolucent shadow will obscure the apices of your maxillary teeth. These are the palatoglossal air spaces. Then next is the positioning of the Frankfurt plane upward. If the patient chin is positioned too high or tipped up, then the hard palate and the floor of the nasal cavity appears superimposed over the root of the maxillary teeth. There will be loss of density in the middle of the radiographs. Usually the characters trispinal are shaped. Maxillary incisors appear blurred and magnified, and reverse smile line, that is flattening of the occlusal plane. If it is downward, it is tipped downward, then the anatragus will be 5 degrees downward. The patient chin is too low or tipped down. Mandible incisors appears blurred, shadow of the hyoid bone superimposed on the interior aspect of mandible, and extravaganted smile line is seen, that is severe curvature of the occlusal plane. You can see the higher smile. Next is the positioning of the teeth anterior to the focal spot. Patient head is positioned too anterior. If the anterior are not positioned in the groove of the bite block, then the teeth appear blurred. So there should be a proper contact of the anterior incisor edge to the bite block. If the teeth is positioned too anterior on the bite block, then it should appear skinny and out of the focus, that is blurred and narrow. Spine is superimposed on the ramus area and premolars are severely overlapped. Teeth, in this picture you can see the teeth are placed too anterior, so the anterior teeth are blurred, not properly seen. Next is the posterior to the focal tuft. If patient has is positioned too far back to the focal tuft, then the anterior teeth are appear to be fat, that is blurred and wide. There is excessive ghosting of the mandible and the spine. Now in this picture you can see that teeth are too posteriorly placed. So in lower picture, right and left, where it is written in OPG, the anterior teeth are shown to be wider. So in this OPG, you can well appreciate the anterior and maxillary interiors, and the mandibular interiors are blurred and wider as compared to the other two. Then positioning of the mid-sagittal plane. If patient head is tilted to one side, then when it is not centered, head is not centered, the ramus and the posterior teeth appear unequally magnified. The side tilted towards the extritube is enlarged. Where when the one side of the head is tilted towards the tube head, it will show as enlarged image. Condylar and neck appears larger. Mandible angle is higher on the same side of the tube. If patient head is twisted to one side, then this causes the mandible to fall outside the image layer. One side in the front of the while the other side is behind the image layer, and teeth of the one side is wide and overlapped, and other side is narrow, ramus and condyle wider than the other side. This is a head turn, left and right, and it is not positioned midline. So structures are smaller on the side to which head is turned and larger on the opposite side. Then the positioning of the spine. If the patient is not sitting or standing with the straight spine, the cervical spine appears as a pyramid-shaped radiopacity in the center of the film. As you can see in this OPG, that in the center of the OPG, that is in the central incisors, lateral incisors and canine region, there is a radiopaque structure which is in pyramidal shape and size. So this is the cervical spine shadow. Positioning of the tongue during exposure. If the tongue is not fully placed against the palate, a dark shadow appears in the maxilla below the palate and apices of the maxillary incisors blur. Then distortion due to the patient movement. If sometimes patient moves from its original position, then there is a distortion of the image. There is a prolonged exposure which results in increased horizontal dimension of the image of the patient. Sudden jerky movements in the direction of the beam shows area portrayed twice. Sudden jerk in the opposite direction to the beam part of the object missing in the image. This is head tipped up. Frankfurt plane is not parallel to the floor. Then there is a square of mandible, palate superimposed over the maxillary teeth. Head is tipped down, then the mandible incisors are being shortened and V-shaped mandible can be appreciated. If head is tipped down, this is the OPG where the patient head was tipped down. Then next is the cassette positioning error. Patient shoulder touching to the cassette vertical, then there will be vertical dark and light bands appear on the film if the patient touches the cassette. If cassette placed too high, if it is placed too high, then the lower mandible of the patient will be cut off. If cassette is placed too low, then the tail of the maxillary is cut off, and if cassette is placed backward, then the horizontal broad line through the middle of the radiograph will pass. You can see these are the cassette errors. Now, if we talk about the overview of this presentation, then the radiographic projection for the parotid and submandibular gland, you can go for the parotid gland, you can go for the radiographic view like OPG, lateral oblique, rotated PAP, intraoral view of cheek. If we talk about the submandibular gland, then you can go for several extraoral radiographs like OPG, lateral oblique, lower true occlusal view, lower posterior topographic view, true lateral skull with the tongue depressed. If we talk about the periapical region, like area of the antrum, then the floor, base of the antrum cavity, relation with the upper posterior teeth, floor, OPG can show you floor, posterior wall, base of the antral cavity, relation with the posterior teeth, allow comparison with the both sides. Standard occipital radiograph view will show you main antrum cavity, lateral wall, roof of or the upper border, medial wall, allows comparison of the both side. If we talk about the posterior topographic radiographic view, then the floor, lower half of the interocclusal view cavity, relation with the upper and posterior teeth. True lateral skull view will show you main intercavity, posterior wall, anterior wall. Linear tomography in coronal and sagittal will show you all this main intercavity, floor, anterior, posterior wall, plain medial wall, roof or the upper borders. Then if you talk about the CT, then the main enteral cavity, floor and various. Then next, if you want to investigate or examine the fracture of the cranium, cervical spine and intracranial injuries, then fracture type. According to the fracture type, you can go for the extraoral radiograph like skull vault. If there is any fracture which is involving skull vault, then you can go for the PA skull, true lateral AP skull. If there is any fracture involving the cranial base, then these are the radiograph which you can view. Then cervical spine, like true lateral of the neck, AP neck, tomography, CT, intracranial injuries, CT. If you want to examine if you want to examine or see the various peroneal sinuses, so it has been divided according to the sinuses. Like to evaluate frontal sinuses, you can go radiographic exposure of the standard occipital, PA skull, true lateral skull, tomography, CT. If like this sphenoidal and the ethmoidal, we can see with the various extraoral radiograph. Then radiographic investigation to examine mandibular fracture sites. According to the anatomy of the fracture site, we can we can go for any investigation as if you want to evaluate any TMJ, different aspect of TMJ, then transcranial, transpharyngeal, OPG, reverse down, transorbital tomography are the various views, and the area seen are written on the next slide. Then various fractures, that is dental alveolar, lymphoid 1, lymphoid 2, lymphoid 3 fracture or zygomatic complex, mesoethmoidal complex or orbital, and various views in which we can see all these type of fractures. So coming to the conclusion, extraoral radiography plays an important role in imaging of the various maxillofacial structure which aids in the diagnosis and treatment planning for the patient. These radiographs helps in the identifying the status and extent of the various pathological condition and lesion, which are impossible to determine by the intraoral radiography. In maxillofacial radiology, before going for any 3D dimension imaging, this two-dimension imaging modality can provide the initial diagnosis and the assessment of the area of interest. However, these techniques have their flaws too. But still, from trauma to tumor, radiologists and surgeons have to rely on these techniques for providing patient care. These are the differences. Thank you.